It's a new heart failure. Can we start ARNI early? Yes, we can start early. So 43% of the proportion of overall patients in global report heart failure registry were having de novo heart. In PREVENT study, 66% were newly diagnosed HFrEF. Now, if you give ARNI to these patients, you can see that the percentage of patients had admitted with heart failure rehospitalization in this subgroup was much less. So significantly lower incidence of CV death or heart failure rehospitalization in de novo heart failure patients. What about the transition study? That is sacubitril/valsartan shortly after hospitalization, just before the discharge. Those patients who were admitted with newly diagnosed heart failure. The study population in this was divided into subgroups based on heart failure history, and then primary and secondary endpoints were assessed. Sacubitril/valsartan or ARNI improves echo parameters in all these patients. So it improved cardiac remodeling and pump function more effectively compared to ACE inhibitor or ARB in these patients. It also reduced the high sensitivity troponin T concentration in these patients. Similarly, when these patients with de novo heart failure, they were given ARNI, they achieved target dose more easily and earlier, and they had less of side effects. So permanent treatment discontinuation were less. So transition study showed that the first line initiation of sacubitril/valsartan in de novo heart failure patients, along with other GDMT, is possible, feasible, and associated with better results. So it should be considered to delay disease progression in these patients with de novo heart failure. Don't leave them alone thinking and saying that he is well controlled on beta blocker and diuretic, plus ACE inhibitor or ARB, and why should I start sacubitril/valsartan? No, you should start because you will help delay disease progression in these patients, and they will fare better over a long period of time. You can see the same thing written by the ACC expert consensus decision pathway for heart failure treatment. You can see the algorithm. HFrEF stage C treatment, ARNI is preferred, and then you give beta blocker and diuretic as and when required. ARNI is preferred choice, and then you reassess the patient. For patients with eGFR more than 30 ml or creatinine less than 2.5 in males or less than 2 in females, with potassium less than 5, NYHA class 2 to 4, you start aldosterone antagonist. For patients who are meeting eGFR criteria, NYHA class 2 to 4, you can start SGLT2 inhibitor. For patients with persistent volume overload and who are symptomatic, you can start or increase diuretics. For persistently symptomatic Black patients, despite everything, ARNI, beta blocker, MRA, SGLT2 inhibitor, still class 3-4, you should think of adding hydrolysine isosorbide dinitrate combination. Those patients who have heart failure with resting heart rate of more than 70 and who are on maximally tolerated beta blocker dose because of whatever reason, you can start them on ivabradine. Basically, optimal guideline-directed medical therapy should be given to all the patients within 3 to 6 months of an initial diagnosis of heart failure. ARNI may be considered as a first-line therapy instead of ACE inhibitor in these patients, and initiation of ARNI in recently hospitalized stable patients with HFrEF, including those who are ACE inhibitor ARB naive, is safe and may be considered. Now we are coming to the AHA-ACC guidelines for the management of heart failure. In patients with HFrEF and NYHA class 2 to 3 symptoms, the use of ARNI is recommended. Period. It's so much better that it should be used. So reduce morbidity and mortality as well. And in patients with previous or current symptoms of chronic heart failure, the use of ACE inhibitor is beneficial to reduce morbidity and mortality when use of ARNI is not feasible. And similarly, when there are side effects and ARNI or ACE inhibitor both are not possible, then you can use ARB. In those patients with symptoms of chronic HFrEF, where ARNI is not to be given, treatment with ACE inhibitor or ARB provides high economic value.